in today's careers webinar, we are focusing on 3 of the professions. So that's osteopathy, orthoptists, and physiotherapists. So first of all, to introduce myself, my name is Janet Folland. I'm an occupational therapist by professional background, and I'm currently working across the system with the AHP faculty across North East and North Cumbria. So in my role, I support the range of allied health professions that together we know as the allied health professions. So can you go on to the next slide, please, Paul? So this is what we are hoping to cover today in today's webinar. We're joined by a range of colleagues to explain about allied health professions, where we work and what we do. In particular, we'd like to provide you with some information on how you can become one of our very valued professions before we excuse me. So the focus for today is osteopaths, orthoptists and physiotherapists, as I said, and there will be time at the end for any questions. So if you have any questions, please put them in the question and answer slot, and then we'll try and pick those up at the end. So if we can go on to the next slide, please. So to begin with, just to try and give a bit of an explanation about where AHPs work. So this webinar is focused on AHPs across North East and North Cumbria by a partnership of organisations working across our whole system. So in that map, you'll see where we are, what the area is covered. So it's a huge geographical area. And as you'll see on those boxes, the organisations that are our health and the care system is NHS organisations, primary care, community organisations, care, nursing homes, prisons, schools, education, voluntary organisations, social services, justice sector. So in all those areas and more, you will find allied health professions working. So a very diverse group covering a wide range of services. And we also cover a range of services from acute and emergency services, specialist services such as stroke or respiratory services, diagnostic services, rehabilitation, mental health and children's services. So as you can see, we are a very broad group of people. So if you can go on to the next slide, please. So who are the allied health professions? For this, I'll hand over to Emily.
Oh, thanks very much, Janet. So on this slide, we really wanted to introduce you to allied health professionals as a whole group of professions. So we're a group of professionals that are distinct from medicine and nursing. So you might have, a lot of people have heard of obviously doctors and nurses in the NHS, and it's often the first thing that people think of in the NHS. But actually, there's a huge range of careers within the NHS and within across all of our allied health professionals who work in all sorts of different settings, as Janet has said. And we have a whole range of 15 different professions that, as Janet said, provide diagnostic, technical, therapeutic and support services in such a wide variety of settings, both within the NHS and outside of it as well. And the range and scope of our professions is hugely diverse. And you can see the little picture avatar underneath that kind of demonstrates the different AHP professions that are out there. And we have 3 of those with us today. So allied health professionals is a term that's used in the UK to cover the 15 different professions that we work in. And AHPs are actually the 3rd biggest workforce in the NHS after doctors and nurses. AHPs are professionally registered and work as autonomous practitioners within their own chosen profession. And each profession has its own dedicated support workforce as well. So they work alongside registered colleagues to support delivery of care in that profession. If we move on to the next slide. So what we wanted to show you here was just if you're interested in becoming an allied health professional, there are a few routes into being an AHP. And you can see along the top of the slide, we've got some boxes that have got bands 2, 3 and 4 in them. And that's information about our support workforce. So to be a support worker, you can come in at band 2 level, and that requires GCSEs in maths and English, and ideally some prior experience in either a paid or voluntary role that's related to health or social care. As a band 3, you would come in with a level 3 qualification, so that's A levels or T levels or equivalent, and again some previous experience ideally within a paid or a voluntary role. At band 4 level, which is often where people progress from being a band 2 or a band 3, you would gain a level 4 qualification degree, such as a foundation degree, and also have more significant prior experience in a paid role, within a particular profession or a service, and a little bit more specialist knowledge of the profession. So you can see there that some of our support workers do progress from being a band 2 up to a band 3 up to a band 4. On the second half of the slide, this is the route into being a registered professional. So being able to be, a physiotherapist or an occupational therapist, or whatever profession that you choose, the route into the registered professions is exactly the same. So along the bottom there, we have, the route from A levels. So you would have, usually most HEI and universities, higher education institutes, require 3 A levels or equivalent. Grade requirements do vary between universities, so it's best to kind of have a specific look at their website and look at their course information. But that, if you meet the requirements at A level and their requirements there, then you can get into a degree programme. There are some university apprenticeships as well. Those numbers are small at the moment, but will likely grow over time. But there's a small number of apprenticeship places, and they are quite competitive. But it is a route that a number of support workers do follow, to be able to progress from being a band 3 or 4 and progressing into more of a registered role. If we go on to the next slide. So this is a bit of an introduction to the allied health professionals that we're going to be covering today. We're going to start with our osteopath colleagues, and I've just popped some definitions on this slide about each professional that we're going to be hearing from today. So osteopaths are experts in the musculoskeletal system. They detect and treat and prevent problems by moving, stretching and massaging a person's muscles and joints. We're then going to move on to orthoptists. They help to improve the quality of people's lives by treating eye disorders and spotting any serious neurological conditions. And the physiotherapists help people affected by injury, illness or disability and frailty through movement, exercise, therapy and advice, and they help people to improve their physical health and activity. I've just taken those broad definitions just from NHS England, but you'll get a lot more insight into the diversity of each profession, but this was just to introduce and get us started and give you some insight and idea. So if we move on to the next slide, we're going to hand over to our osteopath colleagues. So I'll let you guys introduce yourselves, and I'll let you take the floor and present your slides. Thanks so much.
Okay. So hi, I'm Kate. I've studied at the European School of Osteopathy down in Kent, and I graduated in 2021. This is my colleague.
And I'm Barry. Hello, everyone. I qualified in 1988 at the British School of Osteopathy, which has been renamed since, and been in private practice in West Cumbria ever since. So I think we'll just take you through the slides we've got and add some information as we go along.
Yeah, don't know if Mandy's with us. She rang and said she was having some trouble, so I'm not sure if she's here or not to introduce herself.
Yeah, we're one short, I think, so we'll try and manage.
I am in now, but I don't know whether anyone can see me, and I can't see the slides because it says I don't have permission to view the content. But perhaps Kate and Barry are happy to do the majority of the presentation, and yeah. I may then, if there's time, add a couple of points about the way I see practice life at the end, if that's okay. Thank you.
Yeah. Cool. So,
Slide 1. Yeah.
so what is osteopathy? We actually, I think, all struggled to quite define exactly what it all means to us, because it's all, you know, osteopathy is quite an individual practice. But from our Institute of Osteopathy, the official definition is that we're highly trained, you know, allied healthcare professionals who, you know, are well known for their expertise in the evaluation, diagnosis, and management of the entire body. So we treat literally top to bottom, and sort of the way we treat varies on sort of personal preference, really.
Yeah.
So that's just a very brief overview. So if we pop on to the next slide, we can tell you a bit more about the different types. So we all get trained in structural osteopathy, which is the general sort of joint mobilizations, techniques, you know, soft tissue work, so the sort of the massage type skills. But we also have a very broad spectrum of what we treat. So we do different types of visceral osteopathy, which can help with, you know, acid reflux, digestion, that type of issue. Cranial sacral, which is a very specific type of osteopathy in itself. It would need an entire new presentation to describe cranial osteopathy, but it is a very sort of gentle approach. It's less sort of joint mobilizations and more working with the body's sort of natural balance as such. We treat pediatrics, so we treat babies and young children. We also treat maternity patients. We can specialize in sports, and then we can also go on to specialize in equine osteopathy and animal osteopathy. So we can actually do additional qualifications that allow us to treat horses and mostly dogs. But yeah, so it's a very broad practice.
Yeah, I think I would add that I think typically we're thought of as therapists that deal with back pain, but I think that illustrates the fact that whereas that is a large part of our work, there is an option for people to specialise in a lot of different fields. We're well known for treating back pain, but we treat people with all sorts of different complaints and from all sorts of walks of life. And there's a great deal of diversity available if people are wishing to specialise in certain areas.
And then sort of, you know, to add to that, you know, it's a very adaptable career, I think, osteopathy. You know, we're taught the foundations, so you're taught how to do an assessment, you're taught what to expect a body to do, what it, you know, presents as when it's injured. But, you know, like I say, how we treat that, you know, we're all taught relatively the same skills, but how you apply those and what you prefer as a practitioner varies greatly. So it's a really nice individual, you know, like I say, adaptable career, which is really nice. So it doesn't fit, you know, one rule doesn't fit all patients, so you can't expect one rule to fit all practitioners. So it's a nice sort of diverse, you know, practice. Yeah, I don't know if Mandy has anything else you'd like to add to that one, but
I think you're describing osteopathy really beautifully, and we are very patient-centred, and we recognise the uniqueness of each individual patient who comes to us. And as Kate's alluded to, we do see babies through to older adults and people from all demographics, and we're essentially working in the community, but as first contact practitioners. So we have a primary care role, and we're often seeing people with quite complex health conditions, and working in a way that's allied to and supportive of patients as they're travelling through their medical journeys as well. So we'll work alongside GPs and physiotherapists, speech and language therapists and occupational therapists. And we like to take a multidisciplinary approach to advocating for patients' health.
Yeah, that's good.
So we pop on to the next slide, I think. So I just briefly put together a little bit about studying osteopathy. So we usually, well, it's changed over the years. So nowadays you do a 4-year integrated masters, or you can still do a part-time BSc, so Bachelors of Science. I had a quick look at the UCAS website and found out sort of grades and things that are needed. Quite a lot of the courses are based in the south, so sort of Kent, London, I think Swansea have a course, and a few other several places. But it's a really nice degree option if you like a combination of sort of practical as well as sort of theory. It goes through a really broad sort of education, I suppose. You break it down into sort of your first and your second year. So obviously I've only qualified sort of 3 and a bit years ago, so we did first and second year was sort of very much lectures, observations, practicals in class with other students, and then our third and fourth a lot more clinical practice. So osteopaths, we have over 1,000 hours of practical study before we're allowed to qualify. Again, with the university that I went to, the ESO, if people didn't make their grades at A level, they were usually taken on board, but they school, so different programs offer different entry routes, which again is great if you're more practically inclined, unless exam inclined as such. So it's it's a good degree to get onto, but again it's one of those that gives you an option to sort of discuss even if you don't get your grade. So it's definitely worth ringing the universities and things like that even if you don't get what you're expecting. But yeah, I thought I'd just pop a little bit on. I don't know.
Yeah, that's good. I think that's important to for people to remember, that if you're not if you feel academically you're not maybe quite there, there's still a real sort of motivation if you feel as though you've got that hands-on practical sense of wanting to help people. Certainly the colleges seem interested in that sort of motivation alongside the academic achievement, and they'll often sort of work out what else you need to sort of get to the level that they're looking for. So it's good for people to have that awareness and not be put off by maybe a perceived academic achievement that seems a bit intimidating.
So if we go on to the next slide, if that's all right. So we put in a bit about sort of osteopathy in patients. So the first 2 sort of points on there are facts from the Institute of Osteopathy. So usually we have really good results with our patients, and again we do have medical training. So in the 4 years that we do, we are taught how to do neurological investigations, respiratory exams, abdominal exams. So there's been a few times where we essentially catch sort of red flags. So as Mandy said before, we are sort of first contact practitioners. So people come in with broad back pain, and sometimes they aren't musculoskeletal. So we do an awful lot of study to understand the pathology and the complications behind things that can just mask as back pain, for example. So it's a really in-depth career. It's fab. You see everything from like say general mechanical back pain to something you never thought you'd quite see, and referring them off to the hospital to the right sort of walks.
It's important for us to be able to realise what we can treat and what we can't treat, and what needs sort of medical intervention. And that's a big part of our training, working out when it's appropriate for us to treat and when not, and when to refer on. So it's really helpful if we know there's osteopaths who's around our area as well, who we can liaise with and refer onto confidently. So it's a big part of what we're about.
I don't know again if Mandy wanted to add anything to.
No, thanks.
Yeah. Okay. Next slide then, I think.
So, why choose osteopathy? So it's like I say, it's a really flexible, really adaptable career. I had a quick look at some statistics. So 81% of osteopaths are actually self-employed, but we are much more recognised more recently within the NHS. Obviously, personally had experience working in a NHS outpatient physio practice with loads of other lovely physios, and that was fantastic. Really, you know, quick paced. It was fab. But like I say, it gives us the options. So like I say, most of us are self-employed and in private practice, but we are sort of broadening our horizons as a profession. Again, some really nice selling facts for osteopathy. Most of us only work Monday to Friday. So 65% of us don't work weekends. So again, it's great. You know, we see a lot of patients. On average, I'd say most people see anywhere between 6 to 20 a day. 20 is probably our top end. You know.
Yeah. I think the flexibility is important. I think if you become established, you have got a lot of autonomy in how you work, how many hours you work, and so on. And of course, the fact that you're making your own clinical decisions and you're pretty much allowed to, get on with things the way you like to, which is not always available to healthcare professionals. So that's a big advantage. The downside of that can sometimes be you can get a little bit of isolation, if you're working by yourself. So it's important to kind of be aware of that as well. But the privilege of being able to sort of have a glimpse into people's lives and see what you can do to alleviate their problem to begin with, and perhaps dig a little bit deeper into the causes of the issue is one of the foundations of osteopathy, and one of the really attractive elements there. There's detective work to be done, and there's a bit of kind of interpretation of the person that's come to see you, and trying to see what you can do to help. And yeah, it's a big selling point, I think.
Yeah, and again, it's something different every day, which is nice.
Yeah.
You know, if you don't want something that's the same day in, day out, it's a great job. You know, everyone's different. You know, all the symptoms are different. You know, how you treat people is always different. It's great. And again, you know, we get a lot of time with our patients, which is really nice. You know, it's nice to actually be able to, like Barry said, slow down and actually get to know our patients, you know, find out what their lives are like, and that again, you know, plays a big part into how people recover, you know, and how they get better and how they feel. So yeah, I think it's one of those really nice professions that actually gives you time that people need. You know, people this day and age need a little bit of time just to breathe and relax. And you know, it's a very fast-paced world nowadays, but it slows down a little bit when people come in to see us, so that's nice. Popped on there about sort of globally recognised. So osteopaths are, it's a protected title, similar to nurses and physios. We're protected titles as well. So we're registered with GEOSC, which is our governing body. So we are regulated. We're a regulated profession and recognised in the US, Australia, New Zealand, South Africa, France. What else? Switzerland, Finland, Portugal, Iceland, and Malta. So we're
lots of places to go and work.
So there are opportunities to travel abroad with, you know, with the qualifications that you get from studying osteopathy. So it's a really, like I say, really broad profession, but it's a lovely one to be a part of, and it is global. So yeah, and I think that's our last slide, other than I think some resources, some links, but I'm not sure if Mandy wanted to add anything else as we've come to the end of it.
I think you've covered such a broad amount and given a real colour and flavour of our profession. So thanks for that. Yeah,
it's great.
Oh, thanks so much to all three of you. That was really insightful. Thank you very much. So I'm sure if people have got questions, you know, we'll be able to, you know, tap into all of your knowledge and expertise at the end. But I think if we move on to the next slide now, Paul. Thank you. So I'm going to be handing over to Naomi Corbin now, who is an orthoptist and is working in North Cumbria. But I'll let you fully introduce yourself, Naomi, and thanks so much for joining us.
Hi, I'm Naomi. I'm an orthoptist. Everyone immediately goes, what's an orthoptist? Generally speaking, unless you've had the pleasure of our company, nobody knows what we are. We're one of the smallest of the allied health professions. Orthoptist literally means eye straightener. It's from the ancient Greeks, we can thank them. Think orthodontics is straight teeth, we're straight eyes. So we look after anything to do with eye movement disorders and anything to do with childhood vision development. So if we can wander into the first slide, please. So what do orthoptists do? Well, we see everyone literally from cradle to grave. We can begin with, I think the youngest child I've assessed vision on was about 3 days old, right the way up into the ends of adulthood and frailty. We look after those with learning disabilities who may not be able to access conventional sight testing, particularly because we have skills of working predominantly with children. Indeed, this afternoon is a learning disabilities clinic here. We work alongside the oromaxillofacial surgeons to assist people who've had facial traumas or even facial cancers that then need a full rebuild work of their skull structures, and that can impact on how their eyes may move and can result in double vision. So they come and see us and we work side by side with those guys. And we do a lot of work with stroke and neurological conditions, as well as brain injury in the rehabilitation process. It's much easier to teach someone how to learn to read again or learn to walk again if they can actually see one set of the feet in front of them or one set of the text that you're trying to teach them. So a lot of our time is spent making the world come from being two back to being one. We generally are found in hospital outpatient departments, but we also work out in community outreach units. So I work across North Cumbria from Whitehaven to Workington Hospital to the Carlisle Infirmary and down at Penrith as well. Some of my colleagues will work through child development centres or special educational needs schooling, and some are working in specific brain injury units and will work alongside the armed forces for that as well. Me personally, I work mainly in acute but also community hospitals. Sometimes we are working directly with our fellow allied health professions up in the stroke unit as a multidisciplinary team. That's as and when staffing allows. For orthoptists as a profession, we've got quite a broad range of things that we venture into. Some of us become advanced care practitioners in all sorts of ranges of the range of ophthalmics subspecialties. So some of my colleagues over in the Northeast are currently intravitreal injectors, so they're looking after the injections required for those that have got things like wet macular degeneration, which is now our most common cause of sight loss in the Western world. So they receive injections every 4 weeks in order to reduce the fluid buildup in the retina, and those injections can be provided either by specially trained nursing staff or now by orthoptists. We can also be involved in things like retinopathy of prematurity screening, which my colleagues at both Oxford and Alderhay Children's Hospital are involved in. Some run their own services for children with eye cancers. So retinoblastoma centres down in London and in Birmingham are run by orthoptists. We can be involved in research. I have orthoptic colleagues over the border in Glasgow who are now specialist practitioners in public health, because we branch out into so many different branches of medicine. Indeed, I'm dual qualified in public health as well. Some of my colleagues will go on from orthoptics and become optometrists, so they will work in both guises. So they'll see a patient maybe initially as an orthoptist and then see them again for the optometric element of their care. Some go off into management echelons and others venture into football. In fact, the first professor of orthoptics at the Liverpool School of Orthoptics was Manchester United's very own orthoptist for a long period of time and was considered their saviour after their disastrous away kit of 1996 that was grey and they couldn't find each other on the football pitch. So thereafter, all football kits had to be approved by the lovely Gail Stevenson, and she made sure that their eyes were all working perfectly for their football needs. So special careers in the football world. So what do I do in my day? Well, I can be doing anything from measuring vision, which could be your classic vision test, through to assessing children with, or indeed adults with, pictures who've got no other way of communicating. Or it may even go as far as cards like this, and I bet you can see this one, but can't see this one quite so easily. That's disappearing in and out of my screen, but they disappear into the background. So we've got lots of different ways of testing vision. Don't think that anyone is too disabled to have a vision test. They can all be assessed. We just adapt the way that we test. We look after the measuring of squints for surgery and monitoring of neurological conditions. We then discuss shared care through our optometry colleagues and our ophthalmologists. We also work with qualified teachers for the visually impaired, and we spend a lot of time doing making every contact count conversations, everything from diet to smoking cessation, to looking after teeth. We see a number of children where we simply pop up a torch to look at how the eyes are looking, and we get a view of their teeth at the same time for good measure. So we spend a lot of time talking about teeth as well, strangely. The key bit there of my role that I really enjoy, relieving double vision, usually in sites of response of people leaping from their chair and hugging you, because walking around seeing two of everything in life is not really very useful, particularly if you're trying to climb a set of stairs, trying to make a cup of tea, or worse, you're sat even as a passenger in a car and you can see a juggernaut in front of you twice over that looks like it's about to hit you. So generally people are quite relieved when you get rid of their double vision for them. The other thing that's really rewarding is seeing a child go through the journey of having their vision restored through amblyopia treatment. And it's maybe as simple as putting a set of glasses onto them, or a set of glasses accompanied by an eye patch that's worn for a couple of hours each day. And over the course of a few hundred hours of treatment, we get to the other end and we get normalized, or the best vision possible out the other end of it, for them to be able to pursue normal activities in life and maybe even access careers that otherwise they wouldn't have. Next slide, please. So here we have some famous people and their eyes, and there's a little question that's just jumped up, and this definitely is answered by this one. So if we can click through this little comment. So we might recognise this individual as Hillary Clinton from previous rounds of the elections in the US. She disappeared from the tour of the election for a few days, and she'd actually sustained a fall, and when she reappeared, she was no longer in her contact lenses, she was wearing her glasses. And if you look at her left lens, so right as you look at her, you'll see that it looks slightly distorted, and she's got something called a Fresnel prism that's on her glasses in order to bring her vision back into single vision. These use the same technology as lighthouse lens glass. So if you've ever been up to the top of a lighthouse, you'll have seen that the lens on front of that lamp is stepped so that the glass isn't so thick to create that lens structure. It's exactly the same idea with the prism, just instead of it being a dome, it's a wedge shape, and we cut it down into lots of little stripes, and it creates us a flexible piece of plastic that we can then adhere by surface tension onto the glasses, and hey presto, we have no double vision. Those of you who are music lovers might recognise this chappie. You'll notice that his eyes are of appearance of different colour. And it was long kind of a misgiving that he had a condition called heterochromia, hetero meaning different. So brown eye, blue eye. This can be an indicator, if it's acquired, of certain neurological conditions. So it's important that we note things like this when we see our patients presenting. In his particular case, it's because actually he got one enormous pupil and one very small pupil. So you can see more of the iris colouring for one eye than you can for the other. And his was as a result of a trauma that caused him to have one huge pupil and one small. Dame Maggie Smith has long had a condition called thyroid eye disease as a result of antibodies created to her thyroid, which has caused her eyes to look slightly bulging in appearance and the eyes to look like they're turning out. She since had decompressive surgery so that the eye isn't so congested within the eye socket, and has since gone on to have cataract surgery. And then a bit more music for you. Andrea Bocelli was born with glaucoma, and up until he was about 12 years old, he could actually see reasonably well. And then unfortunately, he was playing football with friends, ran into the goalposts and lost the remaining sight that he had. However, this wasn't an end game for him. He's obviously gone on to be a hugely successful opera singer, but he's also a qualified lawyer. So it really hasn't stopped him doing much in life. And there should be one more hiding on here. Folk might recognise this chappie. This is Ed Sheeran. He's been long-sighted from birth and had glasses from early childhood. He had patch treatment at the same time as having a port wine stain removed from his face, which I know that he's talked in the media previously about the trauma that removal process was for him. His squint surgery slightly overcorrected him, so you might notice that his eyes look slightly deviated outward now. And sometimes we go back in and redo surgery on people in this sort of situation, or sometimes we can modify their glasses prescription to help bring them back straighter as well. So there's a touch on the sort of things that we are likely involved in that are out there in kind of well-known people in society. Next slide, please. So presently there are 2 schools for training in England. They are Sheffield and Liverpool. I'm a graduate of Sheffield with a Bachelor of Medical Science. University of Liverpool run a BSc course. There are master's extensions to both of these, and more recently above those in Glasgow Caledonian have opened their own BSc with honours course. More recently still, we have a new course that is a postgraduate entry pre-registration course through UCL in conjunction with Moorfields down in London. And we are, I believe, yet to see graduates from this programme, so this is brand new. It's the 3-year training course as an undergrad with at least 12 weeks of clinical placement each year, and those clinical placements take you all over the country, literally. My furthest north was Glasgow Gartnavel for 4 weeks, and my furthest to the south were Brighton, Canterbury and central London. We therefore get exposure to lots of different subspecialties that different ophthalmology departments specialise in. So I had exposure to things like retinoblastoma, which is an eye cancer in under 7s that can be hereditary or can be a mosaic disease. We also get involved in sites that are specialists in paediatric cataract, and other centres are specialists in things like specific literacy difficulties and Mears-Irlen syndrome. You learn as part of your training anatomy and physiology, psychology and vision perception. You learn physical and clinical optics, so a full year out of my studies was the same as what the optometrist would be doing. We study paediatrics, we study neurology, we study ophthalmology, core orthoptics and electrophysiology. So we work with electrophysiologists as well, but we have a good understanding of what they do. We study pathology, and we do both professional and clinical research skills. Indeed, University of Sheffield, where I trained, your dissertation is an actual research project which has to go out to the ethics board, and you have to perform actual research and present that. University of Liverpool is rather more theoretically driven on that, but the principle is the same. So in a nutshell, that's what we do. For anyone who fancies a taster of what it's like being an orthoptist and what we do, what we study, popped in the chat, there is a little link there to a course being run through St George's through FutureLearn about what we do as orthoptists and what involvement we have with other bits of the allied health professions. And that's us in a nutshell.
Thanks very much, Naomi. That was a brilliant presentation. I learned a great deal there. So thank you. I'm sure everyone will have found that really interesting and have lots of questions probably towards the end, but we're going to move on to our next profession and our final profession today. So we've got 3 physiotherapists with us, well, 4 actually physiotherapists with us on the call today. 2 from Northumbria Healthcare, that's Philip and Danielle, and then we've got Brianna and Katie, who are from Newcastle Hospitals Trust. So we're going to be starting with your slides, Philip and Danielle. So you're up first, if that's all right, if you'd like to introduce yourselves.
Yeah, thank you very, very much. Apologies, I'm still reeling from Naomi talking about injecting eyeballs, to be fair. What a fantastic presentation that was, and a fantastic, interesting career that you're in, which I knew very little about, to be fair. Onto physiotherapy, which I know a little bit more about. So just an introductory slide, really, for Danielle and I to go through before we talk about our careers and our journey and how we got to where we are. And similarly to what was said at the start about the different AHPs and who we work with, largely it's everybody and anybody, from the moment someone's born, very much what Katie will talk about later, and Brianna, to when they're on palliative care, end of life, and everything and every condition in between will have some sort of physiotherapy need of some description that we can be involved in. As a result, it means that we can work in a wide variety of areas, and we work with a large professional MDT. You'll find physiotherapists in every hospital up and down the land, pardon the pun, but we're kind of the backbone. So we might work alongside surgeons if we're on surgical wards, consultants, medics, on other types of medical ward inpatients, work with GPs in the community, nurses, obviously, the entire AHP, including some of those present, and largely the whole NHS workforce, all 1.5 million members of staff. Indeed, sometimes you have physios working in occupational health for those members of staff. We also work in the third sector, so charities, community groups, and private companies as well. A lot of corporations have physiotherapists as part of their staff. And of course, the most important person that we work with is the patient themselves and their families, and they tend to be integral to the work that we do, involved in their goals and decision making, and we try and work in partnership with those. The prospects for a physiotherapist are quite good. Like other people have alluded to, our qualifications are internationally recognized. Many physios leave to travel, go as far abroad as New Zealand, Australia. There's other qualifications to do to work in America, but it's internationally recognized. And typically you'd start out as a band 5 physio after doing your degree, which tends to be a rotational post. And then you progress onwards to a band 6, which could be rotational or static, and typically in a specialized area, like examples there, musculoskeletal or respiratory, elderly, for example. And then beyond into band 7 roles, and beyond that as well, a lot of our senior management in our trust in Northumbria have been physiotherapists in the past. And I think that's in large part because of the amount of transferable skill that you would get from being a physiotherapist that you can take into those more senior positions. It says that where we can work, it's literally everywhere you can think of, to be fair. Outpatients, inpatients, online services, the group classes, first contact physios in GP clinics. We work into specialist schools, we work into care homes, rehab centres, everywhere, Apologies, I'm also Mr. Popular today, get a lot of phone calls. And we can also work in specialized areas. One of my most favorites is hyperacute stroke, so dealing with those people who have just imminently had a stroke within the last few hours and maybe just been thrombolized to try and improve things, and immediately see the physio to try and get either the ball rolling on rehab or getting them across to the right area, or even getting them home on the same day if treatment's been very good. We work in children's wards, community centres and family hubs. Women's and men's health, which Danielle will talk about, and like I've already mentioned, surgical wards, A&Es, pediatric intensive cares, adult intensive cares, and the rest, you name it, we're there in a specialised role doing what we do. Next slide, please, and I'll just talk about my little journey that I've had. So I'm currently the team lead physio in the community response service in North Tyneside. Been a physio for a little while, but I started out as a mature student back in 2014, 10 years ago there. And I had a quite good career as a teacher up to that point for 10 years. So it was very much a career change for me. I taught health and social care, and actually it was only by teaching health and social care that I understood what a physiotherapist was and became more interested in the role and decided to take the plunge and go for it. If you had asked me at 18-year-old what I wanted to do, I wanted to be a motorbike mechanic, I wouldn't have even been able to tell you what a physiotherapist was, and I certainly wouldn't have had the qualifications necessary to do it. But 33-year-old, I decided to make the jump, and I applied for both the master's course and the undergraduate course. Had one interview for both courses through the program manager, and was given the choice there and chose the undergraduate course, mainly because it was a little bit longer. There was a lot more face-to-face time, a lot more training. The master's was much more self-directed learning, and I just felt, why rush things? Why not just take the time? I'm going to qualify at almost the same time, and the master's course started in February, and I was a teacher, and I didn't want to do another term of work. Is the reality. My placements probably are a really good reflection of the variety of type of physio that you do. So I worked in mental health in the first year at St George's in Morpeth. My elective placement was pediatric intensive care because I really wanted to do that as my career. Ironic that I now work in neuro elderly. And then I did stroke, I've done community rehab, I did oncology wards, I did outpatients down in South Tees. My placements were, I was probably quite lucky to have such a variety, but I feel back then there was fewer students on the course because at the time it was dictated by NHS, how many students were on a cohort. But now obviously things have changed and cohorts tend to be a lot bigger. Placements are more of a premium, and you can't be guaranteed as much of a variety as what I had. And like I say, I may well have been lucky at the time, but it certainly felt like every time I had a placement, I was starting from scratch again. It felt like a new job. It's all physiotherapy, all transferable, but every single one was quite bespoke and quite unique. So I was successful in getting a band 5 post after my degree. And I worked in the Northumbria Trust, which is fantastic. And obviously I worked there, so I'm meant to say that. But their focus was very much on well-being, and it came across in everything that they did, from their appraisal program through to the buildings that they have. There's well-being centres in the hospitals. There's staff groups, working party groups set up to support staff with all sorts of issues, problems. There's menopause groups. It's one of the biggest staff groups that there are in the trust. And it's not necessarily important to me, but it spoke volumes at the time when I was looking for where I would like to work, that such a focus was put on staff welfare and well-being. That, and they just had a brand new, snazzy A&E hospital, which was all very exciting. This trust was at the forefront of respiratory care, and physios were putting people on ventilators and leading the plans and doing all sorts of crazy things like arterial stabs and analyzing blood results and informing medical plans, and it just seemed really quite exciting. After I'd done those rotations, and I would recommend that everyone does a band 5 rotation. Don't just go rushing off and working for the nearest sport club and hope that you're going to work for Man U and change their grey kits. Really, you want to get them fundamentals under your belt, because that's what makes you a good physio. Working with the patients, that variety, learning your communication skills. It sounds so cliche, because you'll hear it a lot at school, doing your GCSEs, communication, but it's the one thing that sets you apart from being a good physio to being a mediocre one. I was successful in becoming a band 6 at that point. Like I say, I specialized in neuro elderly. I just had this real sort of click with older patients and patients who were suffering with neurological conditions. And as a result, I rotated throughout neuro elderly, through the inpatient wards, through A&E, community rehab centres, stroke and neuro outpatients. And I think it's probably worth mentioning at this point that every single one of us in the NHS, all 2 million of us, can all make a difference. And we all have numerous times. We've all put in place pilots and projects and service improvement ideas. There's entire departments committed to staff or workforce development who can support you through all this. And sometimes it's the simplest and easiest little idea that you come up with that can make the biggest difference. And certainly I've done things as a band 5 which has, and to quote, and I didn't know this at the time, has revolutionized the way that we work in A&E, for example. So although that you feel like you're a small part of the NHS, even as a student, you'll feel that you're actually a massive member. And the way that leadership works in the NHS now, with it's devolved, and everybody is responsible, and everybody can make that difference. And the other really important part of being a band 6 is being able to take on students. And I think it's very easy when you go to university and you go into all these different places, and mental health and oncology, and they're all quite scary and they're all quite brand new. And certainly that's how I felt as well. It's quite easy to think that you're maybe going to be a burden, or you're asking too many questions, or you're not quite sure. But actually, as a qualified member of staff, supporting students is one of the best things. So never ever feel that you're going to be a burden. You are the future of the healthcare profession. I'm about to just do a return to practice for an OT who's coming back into the profession after a number of years out. I've never done that before. I'm quite excited to do it. So yeah, it's not something that you should ever be worried about when you're going off into your placements. There's more than enough support, and I think we all know how scary the NHS can be and being on a hospital ward. I'm now a band 7 team lead. I'm responsible for a group of therapists. We work in North Tyneside, like I say. There's occupational therapists, there's nurse practitioners, and there's physiotherapists, obviously. And we cover admission avoidance, which is trying to keep people out of hospital, so keep them at home, either with equipment or with care. We do really complex rehab, so patients who, I'm working with a woman at the moment who has a functional issue, so there's no organic cause for this, but she can only go around on all fours, which is incredibly complex, really difficult to sort of unpick and try and improve her life. But we've got her walking outdoors now, so that's a real sort of improvement for her. And she's really young, And then we also provide input into the virtual wards, which is quite a new strategy, really, from the government. So patients who typically would have been on a hospital ward, either because they're receiving IVs, antibiotics, intravenous antibiotics, which would normally only be administered onto a ward. But our nurse practitioners are going out and trying to manage all of these patients at home. And inevitably, these patients also need some sort of therapy input as well. Which is all very exciting, all very new, and you'll find that the NHS is constantly evolving at all times. So it's nice to be part of, nice to have a say. And like I say, I always felt that I had to, become a band 7 to make a difference, but it's really not the truth. You can do that from the moment that you step through the door, even as a band 2 coming into an apprenticeship. Everybody's a leader in the NHS. So my typical day would be that I start at 9 o'clock in the morning. I work 9 to 5. My team's very flexible. So we try to make sure that everybody has a particular, some people prefer to have condensed hours, some people prefer to have flexible working, and we try to adapt that for everybody. So I make sure I start my day by greeting my whole team, and that's not just throwaway comments, it's a lot of stressful work that we do. So spend a long time with my staff to make sure everyone's okay, that everybody who should be in is in, and everybody's quite confident with the workload that they're doing. I obviously check my emails, all hundreds of them that I get every day, and try and make sure that all the work is actioned, or that I've got a plan in place. I do all of the managerial stuff. I was going to say boring stuff there, but I'll not. I'll say the managerial stuff. Staff appraisals, chasing supervisions, monitoring sickness levels, making sure everyone's done their training, or checking HR processes, managing rotas, all the different types of leave you get. That tends to be the stuff that takes up my day now. I obviously also do clinical audits. I analyze data. I'm about to introduce a new audit at the moment, which is very exciting. So I've got a few rotational members of staff who've come into my team, a couple of band 6 physios, and they're going to start measuring sarcopenia, which is basically muscle weakness as you get older. And as part of their initial assessment, they're going to do grip strength, and then as they discharge, they'll measure it again. It's been proven that sarcopenia is one of the best measurements, or grip strength is one of the best measurements for mortality rate. So we're going to see if the kind of rehab that we do in our service actually can benefit people's life quite significantly, improve their life expectancy. So wait and see. A lot of this work has come from the hospital, to be honest, from the orthopedic team who've been doing very similar stuff. I tend to see the more complex patients, or provide the support to my team for those more complex circumstances that arise. And then the best part of the day is 5 o'clock because I get to go home. What do I love most about my role? I love it all, to be fair. But I think what I love the most is improving people's lives. Like Naomi said about correcting vision, that moment where you get that gratification because the patient says, You've made that difference to my life. If it wasn't for you, I wouldn't be doing this. So when I've made that woman go from all fours, being stuck on a sofa as a 30-year-old, to now she's walking outdoors, and she says, if it wasn't for you taking that risk with me, because it was a risk, you know, a lot of other physios wouldn't have tried to walk her. I took a risk. We've made that benefit, you know, and there's no greater feeling in the world. There is no greater feeling. A lot of the work now, I take a lot of that gratification vicariously through my team. You know, we have a lot of good team outcomes now. But I'm there to offer the advice, and that's largely my job role now. So what do I like the least? Well, it's kind of similar. It's the fact that it's not me out there doing the work anymore. I coordinate it, I allocate it, and I'm largely there to kind of facilitate these things to happening. And it can be difficult some days because you just want to be on the road. You just want to be out doing it. But there's many pathways through the NHS, sideways, upwards, and inevitably a lot of those career progressions will take you away from direct clinical contact. But even our physiotherapy head of service still has clinics, still has physio contact with patients, because once you're a therapist, you're always a therapist, and it's difficult to pull yourself away from doing that. So it's what I like the least, but it comes with a job role, I'm afraid. If I could change it, I would, but I like being able to support the team, if I'm honest. So that's me. As a mature student, took a slightly different approach through. But like I say, when I was 15, I didn't have a clue. Motorbike mechanic was the way I was going forward, and I kind of fell into this in a slightly different manner. So irrespective of whether or not you're ready to go now, physiotherapy is a very difficult, academically difficult course to get onto at university. It's very competitive. There's a lot of Irish students over here because in Ireland it's even more difficult to become a physio than what it is to become a doctor. It's just one of those things, and you don't necessarily have to do it when you're 18. Sometimes coming in with a bit of life experience is what might make you a little bit better with a patient, but not always.
Okay, thanks for that, Phil. That's a difficult one to follow up from, but thank you very much. My name's Danielle, and I'm a pelvic health physiotherapist. So, similar to Phil, I was a mature student when I started, didn't really know what I wanted to do when I left school. I did go to university, but just didn't enjoy the course, so I dropped out and got a full-time job. So I worked for the ambulance service. I took 111 and 999 calls for a long time. I'll not say how long, but it was too long probably. And then got married, fell pregnant, and had my introduction to pelvic health physiotherapy because of that. So I suffered with some aches and pains during my pregnancy, which led me to pelvic health physiotherapy, which at the time I wasn't really aware was even a thing, which I'm sure a lot of you out there listening will be very similar. So from that interaction, I became aware of that as a career, and that's sort of what led me into my journey to becoming a physiotherapist. So although I had the specific qualifications and things to go on to university, because I hadn't studied for a long time, I had to do a access course. So I did that at Gateshead College. So that was access to higher education in health. I do know that Gateshead College now offer a specific diploma which is offered for allied health professionals. So you can do one specific to any of the allied health professionals. We'll get you onto any of those degree courses at university now for anyone aged 19 plus. So that's always an option. I then went on to study at Northumbria University. So I studied for 3 years and gained a first class degree qualification. But it was a little bit hindered. I studied during COVID, so lots of that was studying from home. Lots of my placements took place really on ward settings rather than in outpatient settings. So it was very much respiratory care of the elderly ward based. And it was very much within one trust. So a lot of my student placements were done actually in South Tyneside and Sunderland Trust, where some people can see that as not a good thing, because it is great to be able to travel and do your student placements at a variety of different trusts. It worked well for me because it allowed me to build really good relationships with all of the staff across the different sites at South Tyneside and Sunderland, which will become a little bit clearer as to why that worked well for me in a little while. So once I qualified, I secured a full-time post at South Tyneside and Sunderland, but because of health reasons, I had to turn that down. And it was quite unusual that I was then offered to work as a member of the NHS professional staff. So you would usually have to complete your preceptorship and have worked for a trust for 6 months to be able to do that. But because I had done a lot of my student placements within the South Tyneside and Sunderland Trust, it allowed me to enter in on that basis, where I was able to work as and when I was able due to ill health. But allowed me to keep my toe in the door and work as often as I could. And then that led me to then being able to move on and come to Northumbria Trust. So Northumbria Trust has been really great for me, and it's a really innovative trust because it allows for different entry opportunities that wouldn't normally be available. So pelvic health is quite a difficult area of physiotherapy, I would say, to get into. And because of that, because there isn't a lot of opportunities maybe as students and as Band 5 juniors, it's difficult to then recruit into those higher Band 6, 7 posts because we don't have a lot of people who are experienced in pelvic health. So Northumbria, being the innovative trust that it is, they put out a Band 5 to 6 training post, which was perfect for me. It's a part-time post as well, so a lot of immediate roles, shall you say, into physiotherapy tend to be full-time posts, and it can be quite difficult to get part-time hours, but don't let anybody tell you that you can't do that. It is definitely a possibility, and Northumbria Trust, being what they are, have certainly opened the gateway to doing that. So I work part-time, which allows me to schedule sort of around other commitments, work commitments, and still little blips that I might have with my health here and there. Because it's a Band 5 to 6 post, it does involve lots of training opportunities, so lots of continued professional development. And that's true for no matter what area of physiotherapy or whatever healthcare profession you go into. It is expected that you participate in lifelong learning, and that's just to make sure that you keep up to date with like recent research and different treatment modalities that can become available. So that's something to keep in mind when you're applying to become an allied healthcare professional. You will be expected to do that lifelong learning as well. So in terms of my typical day, like I said before, I work part-time, which allows me to work around other commitments. So my job's never really the same day to day. I don't typically work set hours, and depending on what day it is, what rooms are available and things will dictate what I'm able to do. So I'm mainly working out patients, offering pelvic health assessments for patients with incontinence. So that's like accidental loss of wee, people suffering with painful intercourse, pelvic organ prolapse, and problems defecating, so problems pooing. Okay, these are the things that we offer. So we do pre and postnatal operative care for patients who are having breast cancer treatment. And then we've got antenatal and postnatal patients who will see, like myself, who suffer with aches and pains during their pregnancy. So we'll see them in a range of places. We see them in outpatient face-to-face appointments. We also do online classes and face-to-face classes as well. And then you might see us on the wards, so and in inpatient setting as well, where we offer some postnatal care to ladies who've just given birth prior to their discharge going home, to make sure that they've got the best chance of recovering well and just knowing where we are should they need any help, because like I say, not a lot of people know we exist, so the more places we can be to spread that word, the better. In terms of what I love most about my role, again, like Phil said, I think this is true across the board, that it's about changing someone's quality of life. So we might not be the difference between life and death, but certainly can feel that way for some of these patients who we see. So offering help and advice to reduce their pain, education of their condition or treatment really does go a long way in pelvic health. Usually the people who are seeing clinic, they wait a really long time before they try and get help, which can be due to embarrassment or, like I said, not knowing that the service exists. So by the time they come in and see me, they're usually really grateful for any help, any support that they can give, because usually these patients are the ones who've really lost hope in being able to recover, or really have accepted their symptoms to be part of normal everyday life. So you might see advertisements on the telly which sort of indicate that if you have problems with loss of urine after you've given birth and things like that, that it's normal. And in fact, it's not. It's a common condition, but we shouldn't be accepting these things as to be normal. And that's where we come in to try and change that viewpoint and let people know that there is a way that they can actually recover from that and get better. So it is very rewarding, shall we say, the client base that we see.
Oh, brilliant. Thanks so much, Danielle. I'm going to hand over to our two colleagues from Newcastle Hospitals, Katie and Brianna.
Hello, my name is Brie, and I am one of the peds physios in Newcastle Trust. Like Emily said, I am a band 7 on secondment at the moment, working in long-term respiratory paediatrics. And this is lovely Katie.
Hello, I'm Katie. I'm one of the band 6 paediatric physios, and I currently work in oncology, but I'm a rotational physio, so I go around the different areas at the moment.
I don't want to kind of repeat too much kind of what Phil and Danielle have already said. So just briefly, who do physios work with in general? As kind of everyone said, it is from day dot, from cradle to grave, I suppose, as they say, and we work with such a range of MDT members, those in the hospitals. And I think one of the big things from a PEDS point of view is working into schools and communities, Senko staff in schools or carers in the home environment. Kind of there's such a wide range of people that we work into, kind of schools, care homes, foster carers, anything kind of like that. That kind of links in with kind of where do we work. So as part of my job role, I work with children that are admitted to wards, so I do inpatients. I also do clinics and outpatients. I do community. I'm off to Carlisle tomorrow. We work into schools, but we also can cover kind of private work, whether that is paediatrics privates. I suppose a lot of people associate physio with kind of sports and things like that, so there's that side and that strand. So we do cover anything and everything. Sorry, I'm trying to move this. There you go.
So what are the prospects for progression? So as kind of everyone said, really your typical thing is starting off as your band 5. Normally people go into like band 5 rotations and check out all the different areas before they then want to specialize. You can then specialize through physio itself and going to your band 6, band 7, and even up to your clinical specialists and higher. But you can also take down the private route at some point if that was what some people were interested in doing, or you can go into the more managerial side of things, especially if you're in the NHS. You can go through to like the medical director boards and all of those sorts of jobs. So it's a very broad profession that you can work into, and then you can also do other courses alongside to then, like someone said earlier about becoming a advanced care practitioner. We can also do that from starting as a physio as well.
And I suppose just adding to that is the research element. We actually have a lot of incredible physios that work within our team that are doing research projects and looking into that kind of thing. We've had people who are doing the fellowships and doctorates, so there's also that lovely little research branch, as well as smaller projects that kind of Phil was mentioning on wards and development of services. You can also go down that kind of academia and research routes too.
So what kind of activities do we get up to in our typical day? Working with kids, it's quite varied. So on the wards where I tend to be based at the moment, it's a lot of rehab of children that are in hospital because of their cancer diagnosis and the treatments that they are getting at the time. So we try and make their rehab really, really fun. So a lot of it is based around games. So if we have someone that likes football, we'll try and tailor the treatment towards that. If people are more into their arts and crafts, we can go into that as well. We just like to play, essentially, do lots of silly games. We also have hydrotherapy, which is really fun, and it's where we get our kids in the pool, and that really is beneficial for helping with their rehab, especially if they're finding activities that we do on the land a little bit too hard. We also have gym facilities, so we get kids in the gym for using their, the exercise bike, free weights, do a bit of Pilates or yoga, anything like that really. And then we also have our respiratory side of the job, and that will be doing again with children. We end up making it a lot more fun than what you do on the adults. So that could be things like checking their chest and then treating them on an ITU environment, whether that's with suctioning, airway clearance devices, which is more what Bree does, and that sort of thing.
What I will also mention from, say, a community point of view, we've mentioned hydrotherapy, but we do things like rebound therapy, where we get them bouncing on the trampolines. There's all sorts of things that we will access, a lot of developmental play, a lot of positioning work, a lot of working with new parents as well. When you have a sick baby, it is quite tempting to just go, oh, I don't want to do anything wrong. And actually part of our job and what we do is really encourage and empower parents and families to take ownership of it. And how do I adapt what I'm doing to give my child that care and comfort that I still want to give them, even though they're poorly? So how can we support that and empower the parents?
And it's also a lot about just keeping kids moving and active, whether that's through an acute illness or whether that's a more long-term chronic condition, helping kids kind of still be able to live a good quality of life and do all the fun things they want to be able to do. And like you say, working with the families to help that too. So what do we love most about our roles? So for me, it's definitely the variety. You can go into loads of different specialisms, and even within that specialism, every day is different. I spend some of my day working up in clinic with the doctors and the nurses, and on the ward, doing rehab on there. And I just really enjoy that it's so varied, that so every day is different and keeps it interesting. And then I just love the fact that we're there to kind of help children's quality of life and whatever they're going through at the time. Like I say, whether it's an acute illness or a long-term condition that they've got to live with, we're trying to make their life as fun and active as possible.
And I think for me, a lot of the similar things, but actually it's the people, it's the incredible and inspiring children and families that you meet, and the fact that we get to be able to support them along on that journey. I have specialised since in kind of long-term respiratory conditions, and that's kind of your cystic fibrosis, bronchiectasis. It's kids that we meet on the day of diagnosis, we meet them from day dot, and we build such a rapport and relationship with families. It really is incredible, the bond that you can build with those families.
For sure. Can we have our next slide, please?
So for me, kind of what was my journey, and how did I get here? So at sixth form, I studied kind of what's up on the screen there. I did my biology, chemistry, maths, sport, and then general studies. I don't even know if that's a thing anymore. With that, I got what I needed. I interviewed and I was very successful at going to Northumbria University. I actually had the pleasure of being in the same year group as Phil. I studied there for 3 years. I did my 1,000 hours of placement work. Had the pleasure of kind of doing care of the elderly. I went out into paediatric oncology, actually where Katie is at the moment, worked on stroke, worked on some orthopedics as well. And because of my interest in sport, I actually did some volunteer work with Northumbria University Rugby League. So I kind of dipped my toe in both areas. When I qualified, I started and have remained in the Newcastle Trust, and have been here for the last 7 years. I did my Band 5 rotations, which again are listed up there. So my care of the elderly, adult community, surgical wards and intensive care, cardio, ITU and transplant. Then did my Band 5 rotation in neuropediatrics and found my absolute love. I always knew working in paediatrics was where I was going to go, but working there really solidified for that. However, I wouldn't have been the therapist I was going into neuropeds had I not done all the rotations that I'd done. They really gave me some incredible transferable skills that I got to take along with me. Whilst working and doing my full-time Band 5 job, I have kept my toe in rugby league, and have continued to work kind of for Northumbria University and one of the rugby league clubs in the northeast. After COVID and all that shebang of mixing back and going on to COVID ITU for a little while, I knew my passion was paediatrics, and that's when I made the decision to specialise in paediatrics. I have done, and kind of as Katie said, paediatrics for me, one of my favourite things about it is that you get to rotate, you get to try out so many incredible areas. For me, I did paediatric oncology as a rotation, orthopaedics, respiratory and community. Again, learning incredible and amazing skills. And because I got that chance to experience so many different areas, it allowed me to realise that I wanted to specialise further in respiratory, which is where I am now. Currently doing an 18 months comment in paediatric long-term respiratory conditions, and really just trying to make myself the best therapist I can be, and continue to work kind of alongside my colleagues, still trying to get as much experience, whether that's in research, service improvements, clinics, constantly trying to learn. And I think for me, being a physio, the fact you never stop learning is probably one of the best selling points of the job.
Next slide, please. Thanks. So similar sort of setup. I also did my A levels in biology, chemistry and PE, did some extracurricular stuff like usual, like dance, cross country, and I also did a bit of volunteering at a special school, and that was where the idea of maybe working with kids appealed. I knew I wanted to do physio because I loved biology and like learning about the anatomy and physiology of the human body. That was always my best subjects at school. So then that's what led me to do physio. Went to Northumbria like Bree did, studied there for 3 years and did my BSc. I then qualified and also went straight to Newcastle Hospitals for my Band 5 rotations. And so I did adult respiratory medicine, adult ITU. But I qualified in September 2019, and so of March 2020, obviously the world kind of went a bit crazy. And so I then was on the COVID wards pretty early on in my career as well, which was a bit scary, but we got through it. Learnt loads and had a lovely team along the way. After COVID was kind of more out the way, I then went to neuropaediatrics for my final Band 5 rotation, where I was like, this is definitely what I want to go and do. So I then interviewed for my Band 6 in peds, and then I've been rotating around peds ever since as a Band 6. So I've done rheumatology, respiratory, and I'm now on oncology. And just before I came back to work, I had done a 14-month career break where I've been travelling the world. So I've had a lovely time off, and that was very kindly given to me through the trust. And now I'm back in my usual job, and now I'm on oncology.
Thank you so much. Thank you so much, everybody. That's been a whole series of fantastic presentations. So hopefully that's given you a really good overview of 3 of our very valued AHPs. So thank you, everybody. I can't thank you enough for all that. There are a couple of sites we would like to flag up to you before we just go on to questions. We haven't got an awful lot of time left for that. But just to flag up the Aspiring Allies website, so you can see a QR code there that you can takes you to this site, which gives you a whole load of information about all of the allied health professions, including sort of case studies and sort of roles, sort of people describing the roles that they are doing across the whole spectrum of the allied health professions. There's also a really fun quiz that you can take there, which explores which AHP role you might be best suited to, based on the subjects you study, your skills, your personality, etc. It's all a little bit tongue-in-cheek, but it just gives you a bit of food for thought. So I did it. I'm an occupational therapist. I'm a very passionate occupational therapist, actually, but I actually came out as an art therapist on that quiz, which I thought was quite interesting. So just in the final 4 minutes, we've got any questions. So I notice in the Paul.
Oh yeah, sorry, Jenna. I was just going to flag up. There was a couple in the chat and the Q&A. Sorry, you've already seen them, I think.
Yeah, so one question from Suzanne there about will the slides and recordings be shared afterwards? Yes, they will be. So we will forward all the slides and the recording onto you afterwards, along with all the resources that each of the presenters has flagged up, and with some other resources that we've put together as well. There's a question there which I think will be probably aimed at you, Naomi. So it's around the taster sessions in the chat. So that will be the link that you put up. I'm assuming, Suzanne. So is there an age limit on those taster sessions in the chat?
There isn't an age limit. FutureLearn is provided through the British Library. They've got an awful lot of resources, even for us as postgrads now in professions, that you can access as brilliant CPD workshops with the option to opt in or opt out of having achievement certificates at the end of those additional training sessions. So it's an online course of kind of a taste of orthoptics, dip in and out as and when you've got time, and you'll see your progress charted, and there's the option for a certificate at the end of it.
Thank you very much. There's a question here aimed at our physiotherapist colleagues. So why did you choose to be a regular physiotherapist and not a sports one? That's from Maria.
Is that for Brianna at work in rugby league? I used to work rugby union as well. I think Brianna and I both did the same sort of internship at Northumbria. So I'll give it a go at answering, and then Brianna, feel free to jump in and interject. But so I worked for the RFU as both a first aider for rugby games and also for Ponteland Rugby Club when I first qualified, which was great. And working the clinics, you know, the hourly rate was fantastic. Working pitch side, less so, but still, you know, good, worth turning up. And you work in private, you can do your own taxes, and sometimes that has its benefits. But ultimately, nothing beats the stability and the camaraderie and the support of working in the NHS. But it really is each to their own. I've worked in rugby and I've worked with people who have either done physio and dropped out or worked the wards and dropped out because, you know, the first time they walked a corridor with a patient who ended up booing themselves on the floor, and that was enough for them. So the clinical environment is not for everybody. A hospital environment's not for everybody. Our trust has 24-hour physiotherapy. You know, we do crazy on-call situations, and that's not for everybody. It's high stress all the time. Brianna does respiratory with pediatrics. That is emotionally intense. This is not working with a 20-year-old with a sprained ankle. You know, it's really not for everybody, and not everybody's got the resilience to work in this kind of profession. I remember, bear in mind, I was a teacher for 10 years. I remember doing my first on call after about 6 months of qualification or whatever, and shoving some tubes of someone's nose into their lung to try and clear them before I put them on a ventilator by myself at 2 o'clock in the morning, thinking, how have I got myself into this predicament? 3 years ago, I was in the classroom teaching a bunch of kids. How am I here now trying to save this guy's life? And knowing that I was the only person in the hospital with the skill to be able to do what I was doing at that moment in time, scary, really scary. But you know, it's each to their own. There's some people out there, and I know them, and I work with them, who it's MSK all the way, and private practice has a lot of perks, and that's why they choose for the sports. But for me, I was giving up too many Saturdays. It's a big commitment working in that field. It's a lot of evenings. But a lot of people like working in football and working in rugby, and I know there's loads of clubs out there that will bite your hand off to come and work with them if you have a physio qualification. So.
Thank you very much, Philip. And I think I would just sort of probably add into that for all the careers across all the allied health professions, you're not sort of going straight into these really complex situations. Obviously, there is a whole process around your training going in. Yeah. You get trained for it. So by the time you're doing it, you actually feel it might still be scary, but you're trained to do it, and you know that you're able to do it. And actually,
you wouldn't do it if you hadn't done the competencies to do it. Yeah, you're absolutely right. But there's competence and there's confidence, and sometimes you're just there thinking, this is just mad. How am I here?
And I think for all the allied health professions, what you do get is a career that makes a real impact on people's lives. And hopefully this has given you a bit of a taster across 3 professions of the impact that you can make and the contribution to enabling somebody to live the life that they need to live. And you can't ask for more than that. I mean, that's gold dust in terms of, you know, making a difference to people's lives and being able to do that. What a thing to offer. So I just wanted to flag that up. Now we've now gone over. So I think we probably have to bring the webinar to an end there. As we say, we will be sending out the recording and the resources, and I would encourage you all just to explore that Aspiring Ally site and look into all the allied health professions. So thanks again to all our presenters and to the organisers of this webinar, and hopefully we'll see you at the next one, which will be probably coming up. We haven't got a date yet, but it'll be November-ish probably, and that'll be focused on music, art and drama therapies, so very different. So thanks everybody.